Good morning, everyone. Today, we explore one of the most controversial and misunderstood intersections in orthodontics, the relationship between orthodontic therapy and the temporomandibular joint, or TMJ. Why is this important? Because the TMJ is not just another joint. It is unique. It operates bilaterally and simultaneously. It combines hinge and gliding movements. It functions in harmony with occlusion, muscles, and posture. As orthodontists, we are constantly influencing the masticatory system. Every bracket we place, every bite we open or close, every elastic we prescribe. All of these can affect not just the occlusion but the joint itself. This lecture will answer three big questions. 1. How do we achieve orthopedic stability in the TMJ? 2. How do we recognize and manage TMD in patients seeking orthodontic treatment? 3. How do we integrate joint health into orthodontic planning and execution? By the end, you should understand that orthodontics is not just about teeth and smiles, but about creating harmony between joints, muscles, and occlusion. Concept of orthopedic stability. The first principle is stability. Orthopedic stability of the masticatory system occurs when the condyles are seated in a supero-anterior position in the fossae, with the discs properly interposed. Think of it like this. Imagine a golf ball, the condyle, resting in a cup, the glenoid fossa. If the ball is slightly off-center, the muscles must work harder to stabilize it. Over time, fatigue and dysfunction result. The role of muscles is critical. Elevators of the mandible, temporalis, masseter, medial pterygoid generate force to seat the condyles. Lateral pterygoid controls disc condyle complex during movement. The disc itself is not a shock absorber in the way students often imagine. It's fibrocartilaginous, avascular, designed to resist compression, but true stability comes from how the muscles coordinate condylar seating. Clinical pearl. Canines are uniquely designed to accept horizontal forces, long roots, dense surrounding bone, and proprioceptive innervation. That's why canine guidance is the gold standard of occlusion. Locating the stable position. How do we clinically locate this musculoskeletally stable position? By manual manipulation, Dawson technique. Patient supine, relaxed. Fingers along mandibular angle, thumbs on symphysis. Guide mandible supero-anteriorly into seated condylar position. Leaf gauge method. Stack thin plastic wafers between anterior teeth. Posterior teeth disclude. Elevators contract without interference, naturally seating condyles. Analogy. It's like realigning wheels on a car. If you drive without alignment, the tires wear unevenly. If you treat malocclusion without seating condyles first, you risk relapse and dysfunction. Screening for TMD. Before starting orthodontic treatment, we must screen every patient for TMD. Why? Because an untreated TMD can worsen under orthodontic forces. Screening involves history, pain in jaw, temples or face, clicking, popping, or locking. Limited opening. Headaches, especially morning. Examination. Palpate temporalis, masseter tenderness. Palpate lateral pole of TMJ during opening-closing. Listen for crepitus or clicking, but avoid pushing fingers in ear canal. That creates false sounds. Assess mandibular range of motion. Case example, a 16-year-old with class 2 malocclusion and crowding. On palpation, she has tender masseters and a painful click at 35 mm opening. Without screening, we might proceed with retraction mechanics that exacerbate loading. With screening, we stabilize first. Imaging and diagnosis. Imaging is our compass, but we must choose wisely. Panoramic radiographs. Good screening for gross condylar asymmetry, pathology. Poor detail, distorted. Cephalograms. Skeletal and dental relationships. Limited TMJ information. CBCT, 3D visualization of condyles, foci, asymmetries. Lower radiation than medical CT. Excellent for surgical planning and asymmetry cases. MRI, gold standard for disposition. Can show anterior disc displacement, effusion, adhesions, no radiation. Teaching pearl. CBCT shows bone, MRI shows disc. Always remember this division. Treatment planning in TMD patients. Now comes the hard part, planning. Patients fall into three categories. 1. Aesthetic only. No TMD signs, seeking alignment. 2. TMD only, symptoms present, no aesthetic concerns. 3. Both, the complex ones, malocclusion pus TMD. Key principle: always stabilize joints first, then move teeth. How? Use a stabilization appliance, flat plane splint. Monitor symptom resolution. Only when stable, plan orthodontics. Case example: a 28-year-old with deep bite, crowding, and chronic joint pain. Appliance therapy reduced pain within 6 weeks. Then, orthodontics corrected occlusion. If we had started braces immediately, pain could have worsened. Managing symptoms. During orthodontic therapy, what if TMD symptoms appear during orthodontics? First, rule out iatrogenic factors, excessive class 2 elastics, posterior condylar loading, over-retraction, profile flattening and altered joint position, conservative management, NSAIDs, non-steroidal anti-inflammatory drugs, plus moist heat. Behavioral advice: lips together, teeth apart, reduce or eliminate elastics, fabricate temporary soft splint. If no improvement, stop treatment, stabilize with appliance. Better to pause than to push through and create chronic dysfunction. Case study. Let's study a real case. A 12-year-old girl, Asian ethnicity, presented with Class 2 malocclusion, severe crowding, MRI, anterior disc displacement without reduction. Management: appliance therapy, reduced clicking. CBCT confirmed asymmetry. Growth modification, plus orthodontics carefully staged. Outcome: stable joints, corrected occlusion, improved aesthetics. This case demonstrates the sequence: stabilize, diagnose, then treat. Never the reverse. Conclusion. To close, orthodontics is more than straightening teeth. It is about creating harmony between occlusion, muscles, and joints. Always remember, condyles seat supero-anteriorly for stability. Canines are the pillars of occlusion. CBCT shows the bone, MRI shows the disc. Stabilize before moving teeth. And above all, treat the patient, not just the occlusion. You are not just engineers of teeth, you are architects of the masticatory system.